Okay, welcome to Chapter 5, the Ingumentary System. So the ingumentary system is just a fancy word for our skin. So what is skin and what does it do? So skin is our first line of defense against any type of infection. It's composed of approximately 16% of your body's total weight. Obviously, it's exposed to our external environment. Important functions of our skin are protection of the underlying tissues and organs against impact, abrasion, fluid loss, and chemical attack. It excretes salts, water, and organic waste by the glands. It maintains normal body temperature through either insulation or evaporation for cooling as needed. So depending on the weather outside, it's either going to be hot or cold. So cold is insulation, and obviously hot, we evaporation with our sweating through our glands. It produces melanin, which is important in protection of the underlying tissue from the UV radiation. It produces keratin, which is a important protein which protects against abrasion and serves as a water repellent. It also synthesizes vitamin D3, which is a steroid that subsequently is converted to calcitrol, which calcitrol is a hormone important to normal calcium metabolism. It stores lipids in the adipocytes, which is in the dermis, and in the adipose tissue in the subcutaneous layer. And lastly, it detects touch, pressure, pain, and temperature stimuli that relay information to the nervous system. So the skin does a whole bunch of things. It is, like I said, the first line of anything. It's going to send all those messages to the correct part of our body to do the metabolism, inform the nervous system, those glands. There's so many important things that the skin does. So there's two main parts of our skin. We have the cutaneous membrane and we have the accessory structures. We also have something called the subcutaneous layer, which is technically not part of the skin, but we tend to include it as part of the skin. So the first is the cutaneous membrane. It is composed of the epidermis and our dermis. The dermis is divided into two different layers, the papillary layer and the reticular layer. Then we have our accessory structures, which are mainly located in our dermal layer. Those accessory structures include our hair shafts, our pore of our sweat glands, the tactile or messenger corpuscles, our subcutaneous glands, our rector pili muscle, which helps our hair stand up straight when we get goosebumps, our sweat gland ducts, our hair follicles, our laminal corpuscles, our nerve fibers, and then down there at the bottom there's some more sweat glands. Excuse me. Then we have that subcutaneous layer, which is found in our hypodermis. It is not officially part of our skin. It sits below that dermis and the epidermis. There's adipose tissue, blood vessels that run and divide the subcutaneous layer from the dermis. So the dermis, we're going to focus on that first, which is a part of the cutaneous membrane. The epidermal ridges, as we see there, we have that top layer of that epidermis right there, and then we have the epidermal ridge, which kind of makes that peaks and valleys, and we have the dermal papillae, and then we have that dermis below there. So the epidermal ridge comes down into the dermis, which are called dermal papillae, which rise up to the epidermis to attach. So this is how the epidermis and the dermis attach and create that nice, secure lock and key mechanism there. These ridges and papillae create more surface area of attachment, which is a better attachment and more secure attachment. The dominant cell type of our epidermis is our keratinocytes, which is that protein layer which helps create our skin, our dermal part of our skin to be waterproof and tough. Its organization is stratified. Its cell shape is squamous, which is on the top of the surface, and is also keratinized. These attachments are the ridges and the papillae, which we talked about, which create that more surface area for attachment. So we have thin skin and we have thick skin. Those are two different types of skin that are found in our body. Our thin skin is the majority of our body system, our skin layers. Thin skin consists of 4 layers, whereas the thick skin consists of 5 layers. So the thin skin, like I said, is found pretty much on our entire body, our head, our arms, our torso, throughout our entire body. In our thin skin, we do not have one layer, which is found in thick skin only. We do not have the stratum lucidum. That is the only layer not found in thin skin. So our thick skin consists of 5 layers because we have that stratum lucidum, and it is found mainly on our bottoms of our feet and the palms of our hands. This is important because we use the palms of our hands and our soles of our feet. They are exposed to many different things. Obviously, we walk. Even though we wear shoes, we may be barefooted from time to time, but our feet and our soles of our feet bear so much weight. They come in contact with so many different surfaces. They have to be really strong and thick. Same thing with our hands. We use our hands and our fingers for everything. We investigate with our hands. So we want that skin on our hands to be thicker, to be more protective. So we don't, if we touch something, we don't automatically scratch ourselves and cause a potential abrasion for infection. Okay, so then we have our epidermis. So we have different layers of our epidermis. So remember that lucidum is only found in thick skin. We have our stratum corneosum, which is on the top there. We have our stratum lucidum, which is only found in our thick skin. Then our next layers are stratum granulosum. And then we have stratum spiniosum, and our last layer are stratum basale. And then we have that papillary layer of our dermis down there, which are stratum basale. Those ridges and papillae, they interconnect with each other. Okay, so we first start with our very bottom layer, that stratum basale layer. This bottom layer is closest to the dermis. It's attached by hemidesmones to the basement membrane. The basal cells dominate, and those stem cells are able to undergo mitosis. So this is a continuous process, continuous production of cells that are going to help move up through the different layers and create the other layers of the skin. Our cells shed off every 30 to 45 days. And we have these Merkel cells that are found down here, which are important for touch, sensation, and tactile sensation. The next layer up from the basal is our stratum spiniosum. These are roughly 8 to 10 keratinocytes. They have the desmone link cells. We also have Langerhans cells are found here, which are dendritic cells. And this layer helps fight skin cancers and microorganisms. The Langerhans cells are important for immune system response. Next, we have our stratum granulosum, which are approximately 3 to 5 layers of keratinocytes. They are important in making keratin and keratohyalin, which are different types of proteins. So because we're making more proteins, this protein production, they are starting to fill up the cytoplasm of the cell, and they're no longer capable of dividing because that nuclei is starting to degenerate and the cells are getting thinner and thinner. Those membranes become less permeable, so they're becoming a little more waterproof, and those cells are also approaching cell death. Our next layer is our stratum lucidum, which is only found in our thick layer. This is a clear layer only in our thick skin. They are dense, flat cells with no organelles. They are dead and dehydrating, and they're completely filled with keratin and keratohyalin. Then we have our stratum corneum, which are approximately 15 to 30 layers of cells. They're completely filled with dead keratin, which makes them completely waterproof. They're linked by desmones, which, I don't know if you remember from earlier chapters, those desmones, they help create that waterproof tightening of those different cells. It takes roughly 7 to 10 days to reach this layer from the basal from the basal layer, and then 2 weeks before shedding completely off. These are insensible perspiration and they are waterproof. Okay, so now we're going to talk about our skin color. So different genetics, different pigment types determine what our skin, how dark or light our skin is. So obviously genetics include different types of pigments we have, and that dermal circulation is also going to determine what the color of our skin is. So our primary pigments are our melanin, which is produced by the melanocytes in the stratum basale and are dispersed via the melosomes. They can be brown, black, or yellowish. So everyone, doesn't matter what color of their skin, how light or how dark they are, everyone has the same number of melanocytes. So what makes it different between person to person is some people have more active melanocytes than others. So the more active those melanocytes are, the more pigment you're going to show, and therefore the darker your skin is going to be. This is also responsible, melanin is also responsible for the color of our eyes, hair, and skin. So obviously someone with blue eyes, those melanocytes are not going to be as active as someone who has brown eyes. Same thing, someone who has blonde hair versus brown or black hair, those melanocytes in blonde hair are going to be less active, and the brown or black hair is going to be more active. So someone who has albinism has no melanin production, but they still have those melanocytes, because remember, everyone has the same number of melanocytes. It just depends on, are those melanocytes active, or are they not active or less active? So for someone who has albinism still has those melanocytes, but they're just not activated. Then we also have keratin, which comes from our orange vegetables. This accumulates in the epidermal cells and in some fatty tissues. Other factors that can influence the color of our skin is our capillary beds, our keratinization, our UV exposure, albinism, which we have also talked about, and cyanosis. So that dermal circulation, which is that capillary beds, it depends on how close to the surface of your dermis are those capillaries. So if those capillaries are really close to the surface, your hemoglobin, which has a reddish hue to it, is going to have your skin appear a little more with a red hue to it. Some people, like myself, my capillaries are very close to the surface. So if I get really hot very easy, my face flushes really easy, my face turns really red, so I have more of that red tone. Whereas my husband, he is not, his are deeper, so his face doesn't turn as red as mine does. So like I was saying, those people who have more dilated vessels will have more blood rushing through the dermis, will have a different skin color for someone who has more vasoconstriction. So I have more vasodilation, whereas my husband has more vasoconstriction. So my face will flush more than his. Then we have cyanosis, which will give you a bluish color. This is usually visible in our lips and under our nails. This is caused from vasoconstriction and lack of oxygen-rich blood. Okay, so sometimes we can get skin cancer. So this is an abnormal, uncontrolled cell division of our skin cells. It is the most common type of cancer. So comparing liver, kidney, lung, ovarian, testicular, skin cancer is the most common type of cancer we have out there. There are 3 different types of skin cancers that we're going to discuss. We have basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. So basal cell carcinoma, when I'm describing different types of skin cancers to patients, I always say basal cell is the kind that we really want to have, because it's, you see what you get. Basal cell rarely migrates or metastasizes. It is found in our basal layer of our skin layers. It has a very good prognosis. So like I said, if you see what you get. So once we excise that basal cell, if we excise all of it, it's not going to come back. And it, like I said, it will not spread to other parts of your body or into other organs in your body. It is most likely due to overexposure of UV rays. So lots of sun exposure, not wearing your sunscreen like you're supposed to, you're going to get that basal cell carcinoma at a later age in life. Then we have the next one is our squamous cell. This one also rarely migrates, and it does not metastasize as well. It does have a good prognosis as well. The difference between the squamous cell and the basal cell is usually very self-limiting, whereas the squamous cell, it can grow quite large. I've seen some quite large lesions, and it can grow down into through the dermis into the epidermis. It can grow from the epidermis to the dermis and even into the subcutaneous layers. So sometimes excision can be quite extensive. And if it's quite large and somebody just lets it go and lets it go, the excision can be quite large, and sometimes reconstruction surgery does have to be done afterwards if it is a very large lesion and depending on the location of the skin cancer. This one's also likely due to UV exposure as well. Then we have the last one, which is malignant melanoma. This is the only type of skin cancer that can metastasize. It can go metastasize via the lymph system into the other organs. Prognosis is good if you caught it prior to spread. So my father actually had melanoma on his arm, and thankfully it was caught very, very early, and it was excised, and he's never had a reoccurrence. It was, scans showed that there was no metastasis anywhere else. It wasn't in his lymph system. He did not need radiation or even chemotherapy. They excised the lesion, and they just watch him now for any reoccurrence of any possible new lesions. So if he had ignored it and it had grown and spread into the lymph system, then it potentially could have spread and metastasized to other organs in his body. So sunscreen is very important. Wearing, sunscreen on your face at all times. Anytime you go outside, make sure you put sunscreen on. Wearing those UV protective clothing that is out there now. Like I send my son to school all the time in his, we call them his swim shirts or his sun shirts, because that gives them that UV protection, because, kids are outside, they don't like to put sunscreen on, they sweat, it's wiped off. So wearing that sunscreen and being protective is really, really important for later on down the road. Okay, so now we're going to move on to the dermis, which is that layer underneath the epidermis. It is a connective tissue that supports the epidermis. It is consistent of two layers. We have our papillary and our reticular. The papillary is a loose areolar connective tissue, whereas that reticular is more of a dense irregular connective tissue. There are collagen and elastic fibers that are found in this layer as well. And it can also be damaged by UV, and aging can lead to fine lines and wrinkles of this layer. Then below that dermis layer, we have that subcutaneous layer, which is our hypodermis. It's not officially part of our skin. It separates our skin from our underlying structures, allows independent movement of our skin. It has lots of adipose tissue, which is really important for energy storage. Women, we find this adipose tissue in our breasts, our buttocks, our hips, and our thighs. And men mainly find this adipose tissue in our neck, in their necks, their arms, lower back, and buttocks area. Both have abdominal fat and central adiposity that's successfully linked to cardiovascular disease. So if we have increased abdominal girth, I was always taught the apple figure. You have that kind of round belly and those skinny little legs, you're going to have increased risk for those cardiovascular diseases. This area is also a common injection site, since there's no vital organs and blood vessels are sparse in this hypodermis layer.
An example of an injection that could be given would be someone who's a diabetic injecting their insulin. They get injected in their lower abdomen area, the back part of their arm, the buttock area, or even the fatty part of the upper thigh. Okay, so of course, as we know, we touch things, we feel things. So we're going to talk about the touch receptors that are found in our skin. In our epidermis layer, we have our tactile discs and our free nerve endings. The tactile discs are more of that texture, sensation, and those free nerve endings are the touch and pressure. So, for example, if you touch a blanket, a soft, a fuzzy blanket, the tactile discs are going to tell you what the texture of that blanket, that soft fuzziness of it, and those free nerve endings are going to help you determine when you touch something, is it delicate? Is it more of a firm surface? How hard do you have to press down on that object to be able to fully grasp its more of its texture? Then we have the dermis. We have our tactile messenger corpuscles. We have our laminar or our Passian corpuscles and our bulbous Ruffin corpuscles. The tactile are for fine touch and vibration. They're found in our papillary layer. The laminar are found in our for deep pressure and vibration, and they're found in our dermis and our hypodermis layer. And lastly, our bulbous are for pressure and stretching of the skin, and this is found in our reticular layer of our dermis. So just so you know, because there are two names for each of these, for my course, for testing purposes, if I ask you a question regarding these, I will give you both names, like they're labeled here in parentheses, so you're not confused. So you don't have to learn both names, just recognize one or the other. Okay, so with our skin, we have tension lines of our skin. These are formed by arrangement of our collagen and our elastin fibers in our skin. They're organized in parallel bundles to resist applied forces in normal movement. This is clinically significant in many different aspects of medicine. Most notably is surgeons. They typically cut with the lines to reduce scarring. So if you look at the image over there, it shows our mapping of our tension lines of our body. Typically, let's, for example, just because it's the easiest, the abdomen, if we're going to have an appendectomy, removing our appendix, they are going to cut along that tension line of the lower abdomen area to reduce scarring, improve healing. The incision is going to heal that much more quickly because it's flowing with the natural progression of what those tension lines are and how the skin likes to lay. Also, too, when you go to pull that skin back, you have less resistance, possible less tearing of the skin. With movement, post-surgical, any movement that the patient will have, if the suture line or the incision line goes along with those tension lines, that movement will not naturally want to pull that incision back open again. So it's, very clinically significant to understand how these tension lines run. Also, simply too, as a primary care or urgent care, you are often going to have people come in who've had sutures placed. Understanding where the sutures have been placed, are they running along the tension lines, will tell you how many days do I need to leave those sutures in. Depending on the location, you can leave the sutures in anywhere to 7 to 14 days before you need to remove them. So usually high tension areas is what we refer to them as. Those are areas where we have a lot of movement. Typically your hands, your knees, your legs, your arms, these areas are more of your high tension areas because they're going to be moving them more, even if the incision is along the tension line. You are still having a lot of tension due to that flexibility of that joint. So that's just kind of something to keep in the back part of your head as well. Okay, so now we're going to move on to what happens if we damage our skin. So one very typical example of how we can damage our skin is by burns. Burns can result from exposure to heat, friction, radiation, electrical shock, or strong chemical agents. If large areas of skin are damaged, it can compromise the function and the homeostasis of our skin, our epidermis, our dermis, and our hypodermis. Dehydration, electrical imbalance could cause kidney impairment and or circulatory shock. The severity depends on the depth of the burn, which is in a burn center or an emergency room, in ICU. It is determined by the pin test, which the pin test is what it sounds like. It's a pin test. They take a sterile pen or needle, and they determine the depth based upon how deep that pen will go into that burn before they get to fresh, healthy tissue. So also the severity also depends on the total area affected, which is the rule of nines, which we're going to talk about in just a minute. So skin functions affected by burns are our fluid and electrolyte balance, our thermoregulation, and our protection from infection. So thinking back to when we first started talking about the ingumentary system and the functions of the ingumentary system, the number one function is protection. It is providing that protective layer of precious organs and tissues to protect it from outside environments, abrasion, any kind of chemical things, heat, anything like that. So if we have taken away a layer or multiple layers, excuse me, sorry, we now have opened up a window for wonderful microorganisms, bacteria, anything that can come in and potentially cause infection to that underlying tissue. Thermoregulation. Skin is a really important insulator. Without it, we're exposed to all the different environmental changes in temperature, and we're not able to regulate our temperature as well as we could otherwise. And then fluid and electrolyte balance. So there are three different depths of burns that we're going to discuss: the first degree, second degree, and third degree. And most of us are pretty similar with those terms. Maybe not so much as to what is classified by those terms, but we are pretty aware of, we do have three different degrees of burns. First degree is a partial thickness burn. It is only affecting the epidermis. An example of a first degree burn is a sunburn. It's characterized by erythema and inflammation, which is redness and inflammation of the skin, of the epidermis. The skin is, sometimes when you get a really bad sunburn, like your face can look a little puffy. You obviously are very tender if you touch anything that you come in contact with, and it's just very sensitive. So this is probably the most common type of burn that we experience, because all of us probably have had a bad sunburn at some point in our lives. And the image over there shows the how the epidermis is becoming red and inflamed, but everything below and the the dermis and the hypodermis remain intact and undamaged. Then we have our second degree burn, which also is a partial thickness burn. It affects the epidermis and some of the dermis. It's characterized by blistering, pain, and swelling. There is a risk of infection because we are going down into that dermis layer where there's more vessels involved, more nerves involved, just more tissue itself is involved. And it takes approximately 1 to 2 weeks of healing time to completely regenerate the tissue damaged. So that second image there, that grayed out area, is an example of that partial thickness burn affecting that epidermis, full layer of epidermis and partial of that dermis layer. But still see as you look, that hypodermis is still fully intact. The hair shaft, the hair follicle there, it is not affected at all. So none of your major tissues or vessels have been affected or damaged. And then we have our third degree burn. Third degree burn is a full thickness burn. It affects the epidermis, the dermis, and into the hypodermis. The pain receptors are destroyed, as you can see by that picture of the third degree burn, all the grayed out area. All those receptors have been destroyed. which is a wonderful thing. Think of having a really bad sunburn, or think of you touching a hot stove and you getting a burn from the stove, or a hot pan when you're taking it out of the oven. The pain that you are feeling just from that little bit of a sensation. So take that sensation, multiply it by 100, and now we have a third-degree burn. So the fact that your pain receptors have been destroyed at this point is probably a really good thing, because you would be in excruciating pain 100% of the time with no relief whatsoever at all. So with a third-degree burn, because it is so extensive, sometimes it can even affect that blood supply of that hypodermis, and skin grafting is usually required to help regrow that new skin, just because it's so much is damaged, so much tissue is damaged, so many little organelles have been damaged in those tissues that the skin isn't able to regenerate itself like it should, and therefore the grafting is needed. So the rule of nines, this is how we determine how much percentage of our body is burned. The image here shows both an adult and a child. So it's a good idea to understand that the child is very different from an adult. Testing purposes, I want you to focus mainly on the adult, but just be aware that there is a difference. For example, looking at the head, a child's head is typically a little bit larger in proportion to their body than an adult, because they're still growing. So the head is going to be a little bit different from adult to child as well. The trunk obviously is a little bit smaller, so the trunk is going to differ a little bit as well. So when the rule of nines, so we're going to take that is applied to when we talk about adult, because the child doesn't really follow that rule of nine. So those you would just have to memorize if you went into any kind of dermatology or any kind of ICU where you're at a burn center. So if you take the adult body, you can divide everything by 9, and you get those different sections of the body. So the head itself is 9% of our body. Each upper limb, which would be front and back, is 9% of our body. So the left arm is 9%, the right arm is 9%, which includes the area from the shoulder down to our fingertips. Our trunk is 36%, that would be front and back. So 9 divided by 36 is 4. So you could theoretically, let's say if only the lower abdomen is burnt, but the upper chest and the back is not burnt. So you could divide by 4, and you could find the area of that, which would be 9%. So, because the front would be 9, lower abdomen 9, upper chest would be 18, and then the back as well. The lower back was 9, the upper back is 9, 18. 18 plus 18 is 36. So that's just a kind of a quick math equation there. Our genitalia, is the only thing that doesn't follow that. It's 1%. And each lower limb is 18%. So theoretically, the upper part of the thigh, front and back, is 9%, and then the knee down to the toes is 9% as well. So, for testing purposes, just follow this diagram, understand and memorize that the head is 9, each limb is 9, the trunk is 36, the genitalia is 1, and the lower limb is 18 each. So how do we treat burns? The most important part about treating burns is fluid replacement and electrolyte replacement, because we no longer have that protective layer of our skin, which helps with that fluid and electrolyte balance. We need to constantly replace until the body's able to do it on its own. The nutrients need to meet the increased metabolic demands for thermoregulation and healing. Like I said, because once again, we don't have that protective layer, that dermis and epidermis, to help regulate our temperature, which helps promote healing. So we need to artificially mimic that until the body can catch up and start healing for itself. We want to prevent infection. We need to clean. We need to cover the burns. Oral IV antibiotics, topical antibiotics, keeping those burns protected so they're able to heal completely. assisting with tissue repair. So for those third-degree burns, we talked about most third-degree burns need those skin grafts. There are 3 different types of skin grafts. We have an autograft, an allograft, and a xenograft. So the autograft is our preferred option for skin grafts. They are harvested from yourself. So if you have a burn only on a small portion or part of your skin and we're still able to graft skin from a different area, we're going to try to do that first because your body recognizes that it is their own and therefore it is going to accept it. It's going to usually not need multiple grafts unless the depth is very severe, but this is going to be your best bet at your body accepting it and not rejecting it. The little saying there, future is likely to grow your own, but time and money. So what that means is, yes, we could, like the stem cell research, we could potentially grow our own, but if you have really bad third-degree burns and you're needing to have that skin graft now, it's really not an option to harvest those stem cells or that small piece of skin to grow a larger portion. A common area for skin grafts are, if it's available, the inner part of the thighs and the lower part of the abdomen are really common areas for skin grafts, as well as sometimes the lower part of the back or anywhere on the mid-thoracic area down to the lumbar area are common areas for skin grafts. My youngest brother, at about the age of maybe 3 or 4, accidentally slipped and fell, landed on a tree stump that had been burnt several days before. And everyone thought it was out because it was extinguished. It was done the proper way. It wasn't smoldering, but when he landed on it with his hands, it was still very, very hot and smoldering. He ended up with third-degree burns of his index finger and his thumb, which required skin grafts. And I remember, I was still a young child at that point, but I remember they did take skin grafts from himself, from his upper part of his thigh, and to this day, he's never had any additional skin grafting necessary or reconstructive surgery, and he has full function of those of his hand as well. So those autografts are the preferred option just for the simplicity of it and the accessibility, as well as the lack of rejection from the body. If those autografts are not possible, if we have full body burning or very extensive burning where there is just not viable good tissue to harvest, there is an allograft, which comes from a cadaver. Obviously, the rejection is going to be increased because it is not your own, just like any kind of organ transplant, kidneys, liver, heart. You have that risk of rejection because it is not coming from you, but it's still pretty well recepted, and usually the patients do fairly well with the allograft. And then lastly, we have xenograft, which comes from animal skin. This is a temporary solution because that rejection, not ejection, but that rejection is very great because it is animal. And our body, we are made differently. Our genetics are very different. So this is like a temporary Band-Aid until either that stem cells or that small piece of skin can be grown for you from yourself, or if we can find a suitable donor, cadaver donor. So like I said, this is just a temporary Band-Aid to kind of get them through to prevent any further infection from occurring. So prognosis, for example, if we had an 80% burn, we have about a 50% chance of recovering in a young, healthy patient. So that just kind of gives you an idea of how extensive burns are, what our prognosis is. Obviously, the smaller the burn area, the greater our prognosis, the greater our improvement. For example, like my brother, his was one hand, just his index finger and his thumb, and his prognosis was amazing. He's got, yes, he has scar tissues, and you can see where he was burned, where they had to do the skin graft, but he healed very well and very quickly. Versus someone who maybe is in a car fire or a house fire and has, very extensive burning. They're going to have a very long road, and healing is going to be delayed. And even death is even very possible due to not being able to regulate that fluid, that temperature, the electrolytes, the infection. There's so many different variables that can play a role in that. Okay, so now we're going to go on to the second portion of chapter 5, which is the accessory structures of our skin. So we have in our skin, we have our cutaneous membrane and our accessory structures. So the cutaneous membrane includes the epidermis and dermis, which we've been talking about for the first half of this chapter. And down there at the bottom is our accessory structures. It includes our hair follicles, our exocrine glands, and our nails. So in the exocrine glands, it includes our sweat glands and our sebaceous glands. And then obviously our nails include, we're going to go through all the different portions of our nails. Okay, so first we're going to talk about our hair and our hair follicles. The hair follicles are derived from the epithelial columns, and they're composed of dead keratinized cells. They produce hairs that protect our skull, and they produce hairs that provide delicate touch sensation. So those delicate touch sensation can be any of the hairs on our body, in our ears. These all provide that delicate touch sensation. Hair is found almost everywhere on the body. So if you look at yourself, some people will look at yourself in general. You have hair on your toes, you have hair on your legs, your abdomen, you have hair in your ears, you have hair on your face, you have hair on your head, you have hair everywhere. Person to person, it varies. Some people have very, very fine, delicate hairs on their body, very almost white in appearance, and some people have more coarse and darker color hair. The only locations not found is on our palms and our soles of our feet, our fingers, toes, and lips. Each individual, so I'm going to disagree with our toes, because part of my job as a primary care with people who are diabetic, one exam that we do is examine their feet. We check for their pulses, we check for touch sensation, we check for any kind of open wounds or sores, any calluses on the bottom of the feet, but we also check for hair on our toes. So on the big toe, you may only have one or two, but most people have hairs on their toes, and this shows that we have good circulation. So I'm going to disagree with that concept that we have hair on our toes. Maybe they're referring to the tips of our toes, or underneath on the bottom of our toes. No, you're not going to have hair there. But at the very proximal end of our toe, you're going to have a couple little hairs showing that the circulation of blood supply is pretty good down there. Okay, so anyway, that was a side note, sorry. Each individual hair is produced by a hair follicle, which is a complex structure composed of epithelial and connective tissue that forms a single hair. We have two different types of hairs on our body. We have terminal hairs and we have vellus hairs. The terminal hairs are large, coarse, darkly pigmented hairs. These are, for example, these hairs are usually found on our scalp and our armpit area, as well as our genitalia area. The vellus hairs are those smaller, shorter, more delicate hairs, and they're found on our general body surface. So they're found everywhere else on our body. So an example of a test question that I may ask you is, this is an example of a terminal hair. And I would say a hair on your head. True or false? Or this is an example of a vellus hair, arm hair, true or false. So something along those lines is, just be familiar with what is the difference between the terminal hairs and the vellus hairs. So the diagram over there, we have our hair regions and associated structures. We're going to start down there at the very bottom with that root hair plexus, which is a collection of sensory nerves surrounding the base of the follicle. We have our erector pili, which is our smooth muscle, which is attached to our hair follicle. In contraction, it pulls the hair erect and it releases our sebum. So that erector pili, when we have goosebumps, that is the muscle in charge of our goosebumps. That's what creates those goosebumps. It makes our hair stand up straight. We have our hair root, which anchors to the hair and into the skin. That blue kind of like cocoon looking thing is our connective tissue sheath that surrounds that hair root. Then we have our hair shaft, which begins deep within the hair follicle but can be seen at the surface. And then we have our sebaceous gland, which produces secretions to coat the hair and skin surface. Okay, so just a more in-depth picture of that hair follicle. We have down there at the bottom, we have our hair papilla. The hair formation, it begins at the hair bulb, which you see down there where that it's circled around that papilla. It's expanded base of the hair follicle. The bulb surrounds the hair papilla, the peg of connective tissue that is filled with blood vessels and nerves. Then we have our hair matrix, which is actively dividing the basal cells in the contact with the hair papilla. So we're constantly making new hair cells. The medulla, which is a layer of daughter cells formed by the center of the matrix. It's soft, flexible keratin. We have our cortex, which is our thick layers of hard keratin. It's intermediate layer deep to the cuticle. And then we have the cuticle on the outside. Those daughter cells are produced at the edges of the matrix. This forms the surface of the hair, which is that thin, hard keratin, and it's very highly keratinized. So looking at the cross-sectional view there of that hair structure, we have that medulla there in the center. Then we have that next layer of that cortex, and then we have that cuticle layer, that surrounding layer on the outside. The hair follicle structure, we have that internal root sheath, our external root sheath, our glassy membrane, and our connective tissue sheath. Who would have thought hair has so many different layers? So how does hair grow? So we have our first phase, which is our active phase. This lasts approximately 2 to 5 years, and hair grows at a rate of 0.3 millimeters per day. So once we go from that active phase of actively growing hair, then we go into regression and transition. And then from there, we go into the resting phase. The hair loses attachment to the follicle. It becomes a club hair, and the club hair is shed when the follicle is reactivated. New hair formation begins. So, and then number 4, follicle reactivation and growth of replacement hair. So, all your little baby hairs that you see, those are in your active phase. They're growing. We don't really pay attention because we think, they're always little and they're always small. But those are in the active phase, and they're constantly growing for over that 2 to 5 year time frame until it reaches that, okay, this is as long as I'm going to get. And then it goes into that regression and transition. So it's just kind of resting. It's not doing anything. And then we enter that resting phase where the hair is older, it's aged, it's reached its maximum capacity, it's not going to grow anymore, and eventually that shaft dies off, and then that hair falls out. Okay, so we have our exocrine glands. These are derived from our epithelial columns. So we have a couple different kinds of the exocrine glands. So exocrine means pushing outside the body, right? So X out of the body, exit out of the body. Most common when we think of exocrine glands, we think of our sweat glands. They are really important for thermoregulation and excretion, getting rid of those wastes, and regulating our body temperature. The apocrine, endocrine, and merocrine are all examples of a sweat gland. And then we have a different type of an exocrine gland. We have that sebaceous gland, which is also the holocrine gland, and this lubricates our epidermis. So this creates that kind of oily substance that we can feel on our skin. Obviously, when we are younger, going through puberty, these sebaceous glands are going to be very active. Our skin's going to be more oily. Hence why we have some people have more acne than others, just because those sebaceous glands are overproductive and producing more oils. So here's an image of that sebaceous gland. So a typical sebaceous gland, it secretes the sebum into the hair follicle. So we're still talking about the hair follicle here. So that lumen area, this is where that hair shaft, hair follicle is going to be. For this image purposes, that hair was removed, so you can kind of see that lumen better. You have the wall of the hair follicle. We have our basement membrane, and the arrow there is showing how the discharge of sebum occurs from the breakdown of those cell membranes and all of that in that gland. So it's secreted into the lumen, and then it goes up the hair shaft to secrete onto the surface of the skin. So holocrine gland, the cell is burst to release its secretion. Sebum is made of a mixture of triglycerides, cholesterol, proteins, and electrolytes, and this lubricates the hair shaft, and it is important for antimicrobial purposes. So it helps protect that hair shaft, helps protect that skin from invading bacteria. Then we have our apocrine sweat gland. They are found in the axilla, our nipples, and our pubic region. They produce a sticky, milky, cloudy secretion that smells when broken down by bacteria. It is definitely influenced by hormones. So as we age, you think of young children, young adolescent children. They can run around, they can sweat. They don't really have that foul odor of a teenager or an adult. If we sweat a lot, we're going to get more of that stinky smell. So hormones play a huge role in that. These also include our mammillary and our ceruminous, which is our earwax glands as well.
Then we have our aerocrine or merocrine sweat glands. These secrete directly onto the surface of the skin. They are high numbers found on the palms, the soles of the feet, but also across our body. It has a water secretion with salts, and this is important for thermoregulation and excretion of waste. Moving on to our nails, they're derived from a thickening of the epidermis. Their main function is protection of the tips of the fingers and the toes. They also help limit our distortion of our digits, which come under physical stress quite frequently, picking up objects, holding things. Our nails are made up of thick sheets of keratinized epidermal cells, and remember, keratinized are dead cells, and our nail body is, once again, dead cells packed with keratin. The nail appearance is often used for diagnosis of multiple different types of diseases. These cells can produce nails that can be affected by conditions that alter our body's metabolism. For example, if we have pitted nails and distorted nails, this is often a sign of psoriasis. When our nails are concave, these can point to some types of blood disorders. Or if we have thickening or discoloration of our nails, this also can point to a fungus. So the images over there on the right-hand side show different cross-sections of the nail, different anatomical points of the nail. We have our nail root, which is the epidermal fold where the nail production occurs. epiconium, which is also known as our cuticle. We have your lunula, which is that little white crescent moon shape down there at the bottom of your nail. And we have the free edge of the nail body, which is the tip of our nail. So the nail growth extends from the proximal end of our nail at that luna, and then extends to the tip, the distal end of your finger. All right, so with our skin, we have some clinical correlations that we're going to cover. Our three separate ones are aging, hormones, and repair. So aging of the skin, we're going to start on the upper left-hand side and work our way around this cross-sectional image of the skin. The first one is fewer melanocytes. We can see this in any skin color, but we most notably see it in more of a lighter colored skin person. Becomes more evident as they age. The skin becomes very pale. They have, of any color, have increased sensitivity to sun exposure, and they're more likely to sunburn. Obviously, lighter skinned people are going to sunburn a little. We're going to see it a little bit more. Anyone can sunburn depending on their color of their skin. Obviously, in the lighter skinned people, we're going to notice it more, and it may be more pronounced. Then we go over and we have drier dermis. So this is because of a decreased sebaceous gland activity. Something you may see in someone who's a little bit older or the elderly, their skin appears very dry and flaky looking. They necessarily, I deal with 65 and older patients all the time. A lot of them just don't sweat, and they're colder all the time. They don't necessarily wear deodorant as much anymore because they don't have that sebaceous gland activity. With that drier epidermis, we also have the thinning of the epidermis. This is because of the decline in basal cell activity. Those connections between the epidermis and the dermis start to weaken, creating, because that dermis is starting to thin on top. This makes the skin more prone to injury, skin tears, and skin infection. One of the most common everyday kind of injuries of an elderly person is of skin tears. They can easily bump their arm on the door jamb, just accidentally scrape it, or even sometimes if they've scratched too hard, depending on how thin that skin is, they can actually tear that skin and get a skin tear. And then once we tear that skin open, we're increased risk of infection. Because of that thinning epidermis, we also have a reduction in vitamin D3 production, which causes muscle weakness and brittle bones. Because we're reducing that D3 in our blood circulation, now we're having to steal it from our bones, which creates those brittle bones and that muscle weakness. Then we have, next to that thinning epidermis, is that diminished immune response. We have declining numbers of dendritic cells. We have about half of our level of these dendritic cells at the age of 21. As we age, 21 is kind of our magic number. This is at the the greatest we're going to get, and then after 21 we start to decline. This increases the change of the skin damage and infection, so therefore increasing our chance for infection and decreased immunity. So because our epidermis is starting to thin, also our dermis is starting to thin. So we have fewer elastic fibers, and this causes that sagging and wrinkling of the skin because those elastic fibers aren't keeping that dermis more soft and supple and cloud-like. It's now starting to create those small fine lines and wrinkles, and eventually over time creating more of those deeper wrinkles. We also have decreased perspiration. So we're going back to that drier epidermis. This also decreased perspiration because those sweat glands are less active, where they're not sweating as much, and therefore greater risk of overheating. It is really common for anyone 65 and older because they have that decreased perspiration. Those sweat glands aren't working. They get outside, they start working. They're not sweating to cool their body off, and therefore they become really dehydrated and they overheat as well. They get heat exhaustion really easily because of this decreased perspiration. So that's something that I educate my patients on a regular basis to make sure that they're constantly staying hydrated. If they do enjoy going outside or working in the yard, any kind of outdoor activities, to obviously minimize the duration that they're outside, but also be cautious of the time of day that they go. Don't go in the middle of the afternoon, go first thing in the morning or the later evening when it's cooler outside. Reduction of blood supply. This cools our skin and stimulates the thermoreceptors. This makes a person feel cold even in a warm room. So, it decreases the ability to lose heat. So this is another really common complaint of the elderly. I'm cold all the time, even though my house is 80 degrees. That reduced blood supply, because that blood supply helps create that thermoregulation. They don't have that well of circulation through there. Therefore, they're cold all the time. Their hands are cold, their feet are cold. They're wearing a jacket all the time, or they're constantly having to use a blanket, or even changing the temperature in their house. Slower skin repair. This is kind of goes with all of the ones we've kind of mentioned before. We have that thinning of the epidermis, thinning of that dermis. We have that reduction of blood supply. We have the diminished immune response. So all of that will add up to that slower skin repair, because they just don't have that good blood supply to help with those mast cell activation, which creates that skin repair. So, for example, a blister repair in a young adult takes approximately 3 to 4 weeks from start to finish, as compared to a 65 to 7-year-old adult. It takes approximately 6 to 8 weeks to repair, because that blood supply, that diminished immune response, just isn't as good as it used to be. Then we have fewer active follicles. So these are those thinner, we have thinner fine hairs that are gray or white from decreased melanocyte activity. They start to lose body hair, even hair on their head, and some men and women have balding of the head, but those little thin fine hairs on our body start to disappear, they start to go away, and then the ones that we do have start to change to that gray or white color because of those fewer melanocytes. And then last but least, we have altered hair and fat distribution. So this is because of a decrease in our sex hormone levels. So that hair and fat distribution, obviously the fat distribution, we're starting to lose that hypodermis. That dermis is starting to thin, and that epidermis is starting to thin. So we're creating that deficit there. So this slide is a really good slide. It has a lot of information. I encourage you to really look at it, pause the video, rewind the video, go back to the beginning, make sure you understand each one. This is, like I said, is a really good slide and really lays out all the different aspects of aging of the skin. Okay, so now we're going to move on to how those hormones impact our skin for aging, as well as for just in everyday life as we go from a adolescent to a young adult. So the skin is tied to all of our other body systems. So the skin is kind of a gate, it's a door, it's a window, it's opening up to all those other systems, either in or out. All right, so the first one we're going to talk about is the glucocorticoids, which are our steroid hormones. They loosen the connections between the keratinocytes and reduce the effectiveness of the epidermis as a barrier to infection. So remember from the previous slide when we were talking about those decreased sex hormone levels, altering the hair and fat distribution. That is what these steroids hormones are doing. They're changing that distribution. Those adipocytes, those fat cells, they play an important role in the hormone production, which is important for cell signaling in your body. If that signaling or those hormones are decreased, we're not going to get that signal to send out to your hormones, either with your ovaries or your gonads, with your in your pancreas, in your thyroid. All those hormones that are circulating throughout your body are not going to be able to send those signals to those adipose cells, therefore causing a decreased distribution of those fat cells. So those circulating hormones can cause changes and or reductions in the circulating hormones due to the loss of the adipose tissue under the dermis. This allows the communication between our skin and the rest of our body, and so without this, we're going to start to have a decrease in that circulating hormones. Those thyroid hormones, they maintain normal blood flow to the subpapillary plexus. In our sex hormones, they're going to increase that epidermal thickness. They're going to accelerate wound healing. They're going to increase that number of dendritic cells, which protect against cancer cells and those pathogens. So decreasing those sex hormones, we're going to decrease the epidermal thickness, we're going to decrease that wound healing, and we're going to decrease that number of dendritic cells that are protecting against immunity. So that's going back to that previous slide where we have that aging effects of the skin. So then we have our growth factor, which can affect our skin. This stimulates our cell growth and cell division. So this helps us create new skin cells, new adipose tissue, keep our skin nice and soft and supple. It's going to help everything grow. It's going to help that blood supply. So that's really important for the whole stimulation of it. And then we have our epidermal growth factor, or EGF. This is a peptide that has widespread effects on the epithelia. It's produced by our salivary glands and our glands in our duodenum. The main functions are promoting that basal cell division in the stratum basal and stratum spineosum. This helps accelerate the production of our keratin, and this stimulates our epidermal development and repair, and also stimulates our synthesis and secretion in glands. And we also have our growth hormone, which stimulates the fibroblast activity and collagen production, which also stimulates the basal cell division, which causes a thickened epidermis and helps promote wound repair. Another important hormone of the skin is vitamin D3 production. It's important for the absorption of calcium. Cholecalciferol is required to make calcitrol, which is an important hormone in the homeostasis of calcium. As we get older, we also have less sunlight exposure, and therefore we won't be able to produce that calciferol as well as we should. That calcitrol allows calcium and phosphate absorption in the small intestine, where it's broken down and processed and then sent to different parts of our body via our bloodstream. The stratum spineosum and the basal cells can convert the steroid into cholecalciferol using the UV light. Important sources of vitamin D3 or cholecalciferol include fish oil, shellfish. It's found in fortified foods such as cereal. There's a lot of it on there. It'll say, usually the cereal boxes will say fortified. It's also found in, obviously, our milk products. The inadequate supply of the calcitrol leads to impaired bone growth and maintenance. So without that vitamin D3 without that vitamin D, we don't absorb that calcium, we don't produce that calcitrol, so we don't have that healthy bone health like we should. So this is another aging factor when it comes to the skin, because we're not, absorbing as much vitamin D3 from our diet. We're not absorbing it from its sun exposure, which is a major source of D3 for us. And therefore then the body starts to steal that from our bones because we don't have enough of it circulated in our system, which in turn results in those brittle bones, osteopenia, osteoporosis, and then obviously leading to increased risk factor for any kind of fracture due to falls. So that's why it's really important to help maintain that vitamin D3 production, to help maintain that homeostasis throughout our entire body. One of the main things that I do as a kind of a routine blood work every 4 to 6 months, just depending on the stability in the patient, their activity level, their overall health, I always check their vitamin D3 and D2, but mainly D3, because they're not getting that good source of vitamin D3 and calcium in their diet, because as we age too, our metabolism changes, our overall diet in a sense changes. Sometimes economical, a lot of these older patients are on a very tightly fixed income, and so their food sources are very limited. They may get food from food pantries, which obviously is limited based upon availability week to week, month to month. So checking that level is really important for those patients to ensure that their vitamin D3 is adequate. And if not, then supplementation is really important to make sure that they're getting that required nutrition. So what if we have that inadequate supply of that calcitrol, vitamin D, and calcium in children? We talked about older adults quite a bit, but what about happens in children? Those children their bones are still growing. As adults, our bones aren't really growing anymore. We do have a little bit of bone repair if we need it, but overall, our bones are done growing. Children, they're constantly growing. In height consistently. So what happens to that if they are not getting that adequate supply, this can possibly lead to rickets. Rickets is a lack of deposited calcium salts in the bones because not enough calciferol or vitamin D3 is to make the calcitrol. More time outside in our fortified milk, soy, OJ, cereal foods will create that, or I'm sorry, not create, but it will eliminate that deficit. So if they're not able to maintain that deficit, those bones become very flexible. They're very poorly mineralized. And therefore, it can also lead to the notorious picture is a person with really bowed out legs. That is someone with rickets, because those bones became very flexible, almost rubbery like, and then the impact of the weight of the growing person causes those bones to start to bow out, especially those weight bearing bones. Okay, so now we're going to go on to skin repair. There are four different phases that the skin goes through to repair itself. So the very first response is the inflammatory response. This is the initial injury causes bleeding and mast cell activation. I kind of alluded to mast cell activation a little bit earlier in a couple slides. So mast cell activation is really important in that skin repair process, because these guys are the messengers that say, hey, there's something going on. We need to fix this, repair it. We need to send all my helpers down here to create that repair. So those mast cells stimulate inflammation, which produces swelling, redness, heat, and pain. So if you've ever had an insect bite or a cut or anything like that, it right after the injury, you're going to feel that swelling. You're going to have that redness. You're going to feel that warmth of that bug bite or even that cut. And then, of course, you're going to feel pain from that injury. Then we have the migratory phase, which occurs approximately several hours after that initial injury, that inflammation phase. So during this migratory phase, you've had a lot of those mast cells come. They're sending all their little messengers in to say, okay, if I have a wound, a cut, I need to start forming a scab or a blood clot, so you don't continuously keep bleeding and bleeding. So that initial scab forms at our surface. The cells of the stratum basal divide and migrate along those wound edges. Macrophages also move into this area to help remove any kind of debris or pathogens that have the skin has been exposed to from that wound, that lesion. If there's any damage into the dermis, then we have a combination of fibroblasts, a blood clot, and a capillary network that help form that granulation tissue and start that repair process. Then we go to that proliferation phase. This is approximately 1 week after injury. The scab is undermined to migrating epidermal cells, and then that scab eventually falls off. So I'm sure we've all had some kind of scrape or wound or something like that. So if you don't pick at your scab and you leave your scab alone, eventually that scab will fall off on its own, and then you have that nice pink, pretty new skin that is underneath that scab. So this is that proliferation phase where you have that nice pink, pretty new skin. The phagocytic activity is almost completed this phase. It's still working to make sure there's no pathogens, no any debris, any dirt, anything that shouldn't be in that wound, so that wound can heal heal well. The blood clot is starting to almost completely disintegrate because we don't really need that anymore because everything's healing and we're forming that new skin. And those fibroblasts have started to form that collagen fibers in the ground substance. So we're creating that network of that dermis and that epidermis to help it heal back. And then the last phase, the fourth stage, is that scarring phase. This is obviously several weeks after injury. That nice pink skin is now gone, and our skin is now returned to its normal flesh color. It may be a little bit lighter than your normal skin color, just because of that scar tissue that has developed there. The scab is shed completely. The epidermis is now completely healed and formed. We do sometimes have a shallow depression, which marks that injury site. Those fibroblasts continue to create scar tissue, making sure it's repaired completely. This scar tissue is usually inflexible. It's a little bit harder than our normal skin. It's fibrous and it's a non-cellular matrix. So some people, when they form a scar tissue, they form something called a keloid. And so a normal scar, like it has that shallow depression. So it's a little bit like a little divot in your skin. Whereas a keloid is a raised, thickened mass of scar tissue that begins at the injury site and grows into the surrounding dermis. So it's an overgrowth of that scar tissue. For some people, they just are overproducers of scar tissue and they create that keloid formation instead. It's usually covered by a shiny, smooth epidermal surface. And more commonly, the keloids occur in the midline of the body versus the lateral aspects of the body, but not always. They can occur anywhere, but more commonly, you're gonna see them in the torso area. It's more common on the upper back, shoulders, and anterior chest. It's sometimes the earlobes. People who are high risk of making keloids can get them pretty much anywhere. So some people may form them, just kind of randomly, but some people who are higher risk, pretty much any kind of injury or scar tissue or scar or anything like that, they're going to form that keloid to some extent. You can remove them, but they unfortunately will grow back because that's just how your body is genetically made. You just make lots of scar tissue. This can be genetic, so usually if a sibling or a parent or a relative has lots of keloids or makes keloids, the chances of you having it are greater than someone who doesn't have that genetic component.
Good, I'm playing.
Okay, so the next several slides are learn on your own content. I'm just going to quickly go through them, but these I want you to go through on your own. I won't go in depth with them, but make sure you're familiar with them and you understand this content. So it's just the microscopes, which you are going to dive more in depth into lab. It's the difference between the different types of light microscopes and what each of them are going to show you. So just scroll through these, make sure you understand them. It's going to help you in lab as well. And if you have any questions regarding this, please definitely reach out to me or reach out to your lab professor and they will go more in depth with it. All right, guys, this is the end of chapter 5. And after this one, we will be taking our second unit exam. Please email me with any questions or any concerns, any in-depth questions. You can definitely put on the discussion board because others may still have the same questions as you. So it doesn't hurt to put it out there for others to learn from as well. All right, guys, have a great evening. Thank you.